On this computer. I'm here today with Dr. Seth Cohen. Dr. Seth Cohen is at the University of Washington, where he's faculty. He is a specialist in infectious disease, HIV, and tropical medicine. He is medical director of infection prevention control for University of Washington Medical Center. Thank you much, Dr. Cohen, for joining me today.
Thanks so much for having me.
So first question is a large question. When people travel internationally, what respiratory infections are they at risk of? And second part of the question, to what extent do jets figure into all of this?
Yeah, really good questions. We often think about travel being associated with exotic infections, but it's actually the common things that are going to get you. So unfortunately, there are a number of infections that people can acquire through traveling, either just being in close contact with others or just as part of being in a dry, dehumidified environment like the cabin of a plane. So, respiratory infections that most people have heard of are things like rhinovirus, which is the common cold, COVID-19, of course, influenza, but there are many others like parainfluenza, RSV, and others. And, aside from a runny nose or a cough, many of these viruses can cause other things like pharyngitis, which is a sore throat, or sinusitis, which as we mentioned, can be exacerbated by that dry air in the cabin. But Chris, just notice that I'm talking really just about viruses. And I want to really emphasize the point that like 98% of sinusitis cases, for example, are viral. So that means antibiotics will not do anything for it because it's caused by viruses, not a bacteria, there are a few exceptions there. But the other thing, you can think about is, particularly when you're flying, is thinking about ear infections and also sinus infections. It's really can be a plumbing issue, which means things just aren't draining the way that they're supposed to. So some travelers may have issues with eustachian tube dysfunction. That's what happens when you try to yawn or try to pop your ears when you're traveling due to those cabin pressure changes, and that could potentially predispose some travelers to getting ear infections as well.
Got it. Now, there's an implication of what you just said. You just said most head colds, most sinus infections even are viral. A lot of people will keep an antibiotic that maybe they didn't use at home from a few years ago. So this suggests that when you get a head cold, when you travel, maybe you shouldn't immediately reach for that antibiotic.
I completely agree. And actually, that antibiotic will probably make you feel worse. So it's almost always a virus. I think particularly if you're thinking about taking an antibiotic for something, if you suspect you might have pneumonia or a bacterial sinusitis, those are much more serious conditions, and I would talk to a doctor before self-administering it.
Got it. So maybe see a doc before you make the decision to take or not take an antibiotic.
Completely. And traveler's diarrhea I'd put in a totally different category. Hopefully you've seen a travel medicine specialist before you go and receive some instructions about when is an appropriate time to think about taking an antibiotic for traveler's diarrhea.
Now, specifically concerning COVID-19, anecdotally, I've heard a ton of stories of where people feel fine at home. They go to Europe or Africa or wherever, and they get COVID. And my question for you is there research that actually shows that travelers get COVID more often than do people who stay at home?
Yeah, it's a good question. I think the way I think about it is most humans are social creatures, and COVID has really exploited this by evolving into this very highly transmissible pathogen that just thrives on social interactions. And so travel can certainly facilitate this. Staying home will probably prevent you from getting infected, but that of course comes with a number of trade-offs as well, including not getting to travel. So I suspect most of the transmission happens at the airport or on shared ground transportation, possibly when you're sitting on the tarmac. But when you're in the air, the cabin air is generally quite clean, and that's due to the air exchanges are usually excellent, and there's good air filtration that happens at cruising altitude. So unless you're really sitting adjacent to patient zero, the risk goes way down when you're actually in flight.
Now, these days, it's kind of a complicated season because head colds go up and influenza goes up in the winter. There's a COVID spike in the summer. You stay at home, you travel. When do you recommend people mask? And when do you think it's okay to forego masking?
Yeah, that is a very thorny question. And I think it's really
That's
become
why I asked you.
yeah. I think it's really become a highly personal decision for people. And I think you sort of take into account, the person's risk tolerance, their personal risk, for example, if they have underlying medical conditions, including whether they're immunocompromised, but also the degree of community transmission as well. And so I think all those factors line up differently for people. So, for example, for somebody who's up to date with their vaccines, is at otherwise low risk of complications. Maybe they don't live, for example, with somebody who is at increased risk. There's probably not a significant benefit to masking, particularly when, community incidence is low. But you can imagine scenarios on the complete other side of the spectrum that might involve a number of vulnerable patients, particularly patients in my clinic, who will often favor masking while traveling. As an aside, Chris, the CDC has launched a new dashboard that shows levels of respiratory viral infection in the US, including COVID, but other infections as well. And so a number of folks, particularly if they want a more data-driven answer, may turn to some of those dashboards to help them think about, when it's more risky than other times to travel, and then think about masking being in the mix.
Nice. So it sounds like that's a nice resource on the CDC, those dashboards, and it's not a one-size-fits-all answer.
Absolutely.
Okay. Next question. A lot of studies, or a few studies, have come out showing there's actually an elevated risk of heart attack after getting COVID for some time. If you get the vaccine, can you mitigate in some way that elevated risk?
Yeah, that's exactly right. Just backing up, COVID can certainly cause myocardial injury through a number of different mechanisms. So one of those would be myocarditis, which people may have heard about. That's an inflammation of the heart muscle, but also heart attacks or myocardial infarctions. And so there have been several studies that have shown that this association with heart attacks and COVID, actually, it can occur during acute COVID infection, but can also be a manifestation of long COVID as well, which is quite concerning to me and many of my patients. So I would say, in answer to your question, COVID vaccines have really consistently been shown to decrease the risks of long COVID, and they also decrease the severity of acute COVID infection. And I think it would stand to reason that they would likely reduce the risks of heart attacks related to COVID infection.
So it sounds like the vaccine not only reduces risk of COVID, which can be life-threatening, rarely, but it can reduce the risk of life-threatening complications of COVID.
That's exactly right.
Good to know. Next question is on RSV. I think most people are familiar with head colds and influenza, and increasingly we're learning about COVID. RSV and the vaccine is new to some people. Can you just give a brief synopsis of what RSV is and who should be vaccinated for it?
Yeah, I love this question. For many people, RSV, or respiratory syncytial virus, it's a respiratory virus that for many people can act just like the common cold. And so in the US, RSV season starts, probably in a few weeks would be my guess. So usually in the fall and peaks in the winter, but really varies. So that's sort of the mild manifestations. But for other people, it's a really important cause of bronchiolitis and pneumonia, particularly in infants. And it's actually, you may know this, it's the most frequent cause of hospitalization in US infants. So big issue among our youngest patients. Leading cause of pneumonia worldwide, and then particularly in older populations, really an important cause of pneumonia or lower respiratory tract infection. And one of the reasons I like this question so much is we are just in this golden age of RSV prevention. And that's really due to NIH-funded breakthroughs in RSV vaccines. And these are vaccines that have eluded researchers for more than 60 years. So really a true medical breakthrough. And there are actually several vaccines to choose from now. So, just to answer your question about who's eligible. So this is a little bit of a moving target. The CDC just updated it this year. So the CDC currently recommends a single dose of RSV vaccine to protect all adults over the age of 65, over the age of 75. So that's a blanket recommendation over the age of 75. And then there's a narrower recommendation for people between 60 and 74 who are at increased risk of severe COVID. So those are all the folks who have medical comorbidities or compromised immune system or other conditions that may increase their risk. So everybody over 75 and then a select group between 60 and 74. Those are for the older folks. But then there's some other really important demographics to think about. So I mentioned that this is such an important cause of infection in infants, in young children. And so the CDC recommends a maternal vaccine. So
Mm,
for
mm,
everybody who's pregnant, it
mm.
should be given during the weeks of 32 to 36 weeks of pregnancy. And that's because it protects the mom, but also the mom makes the antibodies, passes those on to the baby, and then the baby gets protected as well.
Sweet.
So yeah, it's amazing. So great intervention for people who are pregnant. And not only do we have these vaccines, but there's also this monoclonal antibody that can be given to babies after birth and some kids who are just a little bit older than that. So we just have all of a sudden went from having very few interventions to having multiple vaccines, including for older folks, people who are pregnant, and then these monoclonal antibodies for babies. So really revolutionizing prevention of this infection.
And given how common RSV is in infants and how severe it can be, this is really a big deal.
Oh, it's a huge, huge deal. Yep, it's very, very exciting.
Next question. Suppose you're either at home or abroad and you get typical head cold symptoms. You get a runny nose and a cough. Is there something about your runny nose and cough that can tell you that it's a head cold or influenza or RSV or COVID or something or none of the above?
The short answer is no, unfortunately. I've learned that the hard way. It's just incredibly humbling. I have completely given up trying to predict who has what virus. They all have overlapping presentations ranging from just incredibly mild, just a little tickle in your throat or just a very mild headache to very severe. And so it can be any of those. And it's even if you just have a little tickle in your throat, we've heard many times people say, "Oh, it's not COVID," and it turns out to be COVID. So it's that's one of the benefits of doing some at-home testing is we now have reasonably good at-home tests for COVID, and certainly if it's negative the first time around, we'd actually advise you to test again after 24 or 48 hours to make sure that it's not COVID.
And maybe even add to your standard packing list in this era a couple of COVID self-test kits.
Yeah, I think that's a great idea.
Okay. Last question. We've talked about immunizations as a way to bring down risk of these infections and masking. Any other measures come to your mind other than those two that may bring down your risk during travel of respiratory infections?
Yes, there are a number of things that people can do. I would say number one, which is my favorite by far, based on my role in infection prevention, is just frequent hand washing or the use of hand sanitizers when you travel. And if you can combine that with fighting the urge to not touch your face, you're really reducing your risk for infection significantly. I've probably touched my face a few times already during this conversation, but so it's hard to do, but try to keep that in mind when you're at the airport. Hopefully, in addition to that, people are using good cough or sneeze etiquette, sneezing into their elbow, and that's to really reduce the risk of spread to others. But other things that you can do are trying to minimize time in areas with poor ventilation or in very dry air, which is where respiratory viruses can really thrive.
Mm-hmm.
Uh, we've covered this earlier, but particularly for people who are at high risk for complications, they may want to avoid crowded areas or gatherings, particularly when there's a peak in respiratory viral activity. I think one, modifiable risk factor, which often gets overlooked, is smoking cessation. I, have a number of patients who smoke both nicotine, but also, inhalational marijuana. And for many people, I would say marijuana can be a safe recreational substance, but what I'll often talk to my patients about is thinking about actually switching to edibles to really decrease all of the harms of smoking if they want to continue using marijuana recreationally. And then there are other things that are important as well, and easier said than done. So getting enough sleep, getting balanced nutrition, regular exercise, those things keep your immune system healthy. I would say one of the most common questions I get from patients is, are there other things that I can take? Are there immune boosters or supplements or things like that? And what I usually say is we do have immune boosters, and those are called vaccines. Nutritional supplements are a highly profitable industry. And if I truly had a way to boost somebody's immune system that didn't result in, development of autoimmune disease, we would do it. But we just don't have any effective supplements, that really keep people healthy beyond just eating a balanced diet.
So
So,
no,
so those are the things that I'd recommend. Is there anything that I missed, Chris, or things that
that
you
sounds
recommend?
lovely. No quick fix. I totally agree. And I'm glad you mentioned touching your face. I've read some fascinating studies where they filmed people and people touch their faces really often and even put their fingers in gross places, which I'm sure is a great way to spread germs.
Yeah, that's exactly right. Yeah, and in the age of Zoom, we see people doing this all the time.
Thanks so much. That was super helpful. Dr. Seth Cohen, University of Washington. Appreciate your time.
Well, thanks again for having me.
Take care.